Good morning and a warm welcome to all our participants online as well as offline. I'm here to brief you about the neuroanatomical and neurophysiological basis of TMS, which will form a base so that you can understand the other concepts which will be delivered by our senior speakers. The learning objectives of my presentation would be to understand the basic principles of how rTMS works, to learn the key neuroanatomical targets of rTMS in psychiatry, to understand the neurophysiological mechanisms underlying the therapeutic effects. And we'll lay down a structure so that we can understand the clinical implications and rationale for target selection. So TMS is a non-invasive brain stimulation technique which uses electromagnetic induction. Excuse me, am I slide? Thank you, sir. So TMS is a non-invasive brain stimulation technique. It uses electromagnetic induction to modulate cortical activity. What is a common misconception is that it is the magnetic currents or magnetic stimulation of the brain. But actually what happens is that the magnetic field, the changing magnetic field induces currents inside the brain cortex. So the brain cortex, being a conductor of electricity, it acts as a base where the induced currents can move, and thereby bringing about the changes which help in therapy purposes. This developed in the 1980s and now is widely used in research and clinical settings. TMS basically runs on the Faraday's laws of induction, which says that a rapidly changing magnetic field induces the electric currents. I think the brief video here is self-explanatory, that how a changing magnetic field generated by the coil in our machine induces currents which then modulate neuronal excitability. So now that we know that it is what TMS is and how the electric currents are produced, we move on to what are the types of TMS. So what is most commonly used is single pulse and repetitive magnetic stimulation. Single pulse is more of diagnostic value, and rTMS repetitive pulses have therapeutic effects. Going on to the actual types of TMS, like I said, single pulse TMS measures cortical excitability. We can use paired pulse TMS to evaluate intracortical inhibition or facilitation. rTMS, which is the main topic of our presentation, and CME, this is the modulation of the long-term modulation of the cortical function. And theta burst stimulation is the newer variant of the way of stimulation in which short bursts are produced, and it is said that it is more in alignment with the actual cortical activity of our brain. So this is the most recent technique, and it helps us deliver TMS therapy more rapidly in more number of patients within a short period of time. So now moving on to the neuroanatomical targets of rTMS. We have to understand that since the magnetic field which we are generating through the coils, they exponentially reduce in their intensity from the distance, in parallel with the distance from the coil. So what we can access through the effects that we can produce is only on the superficial cortical structures of the brain. So these are the major areas which we target: primary motor cortex, the dorsolateral prefrontal cortex, and the occipital cortex in certain cases. Also, there is secondary modulation of the connected subcortical areas via networks. So we have to understand that though the magnetic field cannot reach the deeper parts of the brain, but through these subcortical connections that we can see from the figures, we can modulate changes in the deeper structures as well. Plus, now with developing technology, there are other kinds of coils which help to access the deeper structure also, which we'll discuss later. So like I said, dorsolateral prefrontal cortex is the key target area. The left DLPFC is the one which we use in major depressive disorder, and it is the target of what we call high frequency rTMS. The right DLPFC is sometimes the target for low frequency rTMS for anxiety disorders or depression. Now, other experimental and alternate targets are being used and in research. We are using the medial prefrontal cortex in PTSD or OCD, the anterior cingulate cortex in mood regulation. After DLPFC, the supplementary motor area is also being in use, and inferior frontal gyrus. These are areas of research right now. These will be discussed in more detail by the other speakers. Now, coming on to the anatomical landmarks, how do we locate the area to be stimulated? So, like in our surface landmarks that we do in our UG studies, so we have certain areas and we use the location of the approximate location of that area through an area which we can directly check. So the motor area is something which we can stimulate and directly observe the changes in the form of movements in the fingers or the thumb. And using this motor area, we use a 5 to 6 centimeter area anterior to the motor cortex along the parasagittal line. This is the most common way of targeting the DLPFC, which is the most common target of our therapeutic interventions. Apart from that, with research and with more developments, we even use neuronavigation for precise targeting of the brain areas. This shall be discussed by our other speakers. We have to understand the functional neuroanatomy to know the basis of therapeutic treatments. So motor cortex is the area which we use to see motor evoked potentials, which can be directly observed. So this is mostly used for locating the other areas where we want to target rTMS. The prefrontal cortex is the area which is most often used for therapeutic purposes. We should know that this is the area which governs the executive functions and mood regulations. So that is why it is the most important target for our interventions. The parietal cortex also involved in attention and spatial awareness. There are other areas which are being researched and which are being used for therapy, especially for things like persistent auditory hallucinations in cases of schizophrenia. Coming on to the neurophysiological mechanisms, it is a depolarization of the neurons via the induced currents, which is the primary mechanism. Also, it is proposed that there is synaptic plasticity, which is there in our cortical structures, which helps in the long-term changes in the brain which happens. So this is mediated by long-term potentiation or long-term depression of the cortical areas. And for this, we use high frequency and low frequency of TMS. Also, it is postulated there is a modulation of GABAergic and glutaminergic activity in the brain. And the network level effects, like I said, that there are other effects which happen in the deeper structures through the networks that we had discussed previously. So those network level effects are mediated via cortico-cortical and cortico-subcortical connections. This is how usually coils are placed, and this is the setup of giving stimulation. We can observe that just the placement of coil can also affect how much activity is received in the brain and precisely which area receives the stimulation. Now, coming on to the mechanism of action in detail, like we said, electromagnetic stimulation, a rapidly changing magnetic field produces electric current and causes the depolarization of the neurons, and the direct cortical effects and downstream network modulation is affected thereafter. We had discussed briefly the frequency dependent effects. The high frequency of rTMS produces an excitatory effect, and the low frequency causes an inhibitory effect. So as per the desired effect that we target, we can use different frequencies. And like I mentioned, theta burst stimulation, this mimics the natural brain rhythms. And we use intermittent TBS for excitatory and continuous TBS for inhibitory responses. Further neuroplasticity, like I said, there is a modification of the synaptic strength in the local and remote areas. And this is mediated via the cortico-cortical and cortico-subcortical structures and circuits. The network effects overall, rTMS modulates that a default mode network, salience network, and cognitive control network. So these are actually what is happening inside the brain, and the functional connectivity changes. We can now measure them using fMRI and EEG studies along with rTMS. So we have facilities of using rTMS along with fMRI or other imaging techniques so that we can monitor these changes and monitor whether we are reaching the exact target area or not. Now, how to measure TMS effects? The motor evoked potentials are what are generated from the stimulation of the motor cortex. So like you can see in the figure, the TMS coil is where due to the flowing of electric current, a magnetic field is generated, and it is usually perpendicular to the coil. The maximum activity, the maximum field that is generated is at the center point of the coil, and we try to maintain as much proximity to the area targeted through the central position. Like I said, as we move away from the coil, the field exponentially decreases. So to gain a maximum effect, we have to maintain as proximal placement of the cortical structure to the coil as possible. We can also have EEG coupling to view whether we are reaching the precise location or not. And like I said, TMS, fMRI can also be used for network effects. We can ultimately see the behavioral outputs with our cognitive and clinical task performances. So we can see in this figure, when the superficial cortical regions are stimulated through the descending pathways and through the corticospinal tract, they reach the motor neurons, and thereafter stimulus is produced, which can be seen in the form of motor evoked potential on our EMG and other devices. So this would be dealt with my following speakers, the areas where TMS is used. This figure briefly shows us that what superficial structures we can access through TMS, and they can be used in different therapy and different indications. So briefly, I'd like to mention that this is mostly studied in depression, and it is FDA approved for the same. And mostly we target the left DLPFC, and like I mentioned before, the right DLPFC is sometimes used for low frequency stimulation. This is also used in research for smoking cessation and other experimental areas like chronic pain and bipolar depression. Now, coming on to limitations and considerations of rTMS, there is a depth limitation. What we can reach is mostly 2 to 3 centimeters from the scalp, like I've already explained. Also, there is always a chance of variability in the individual anatomy. So when we use neuronavigation, we can be more precise about where we are actually reaching. So the 5 centimeter rule is a mere approximation that we use, but there may be individual variations. There are minor side effects like discomfort, headache. Rarely seizures may occur. So when we screen the patients, we have to make sure that they don't have an underlying seizure disorder. There are other screening criteria we'll discuss. Because of the stimulation, there is a direct stimulation of the temporal muscles, and that stimulation is the reason why patients often have discomfort and headache. So we usually, if it is mild, we gently reassure them, and mostly these effects go away with time. But if it is very bothersome, then we might have to abort the therapy. There is a very much importance of precise coil positioning. So an approximation and with individual variability, we might be actually missing out the real therapeutic areas. The other limitation, of course, are the cost, the availability, and of course, the lack of response in 30 to 40% of patients. I think with developing technology and with more widespread use of rTMS in institutes, the cost factor we might be able to overcome, especially in government institutes where we are able to provide this therapy at a very minimal cost to our patients. We have already discussed this. The common side effects are scalp discomfort and headache. Serious side effects are seizures, which we have to look for. The contraindications, the major contraindications of rTMS are metal implants in the head and a history of epilepsy. Future directions would be dealt by our other speakers. The figures briefly show what is deep rTMS. So these are the coils which are used for accessing the deeper structures of the brain. But the limitation of these coils are these are for individualized treatments. We cannot use the same coil for other kinds of treatment. So if we have a deep coil for OCD, we can use it only for OCD patients. Whereas the other coil that we use, the movable coil, we can place it in different areas and use it for different indications. I'll summarize that TMS modulates the cortical activity via magnetic induction, and it targets specific cortical and network regions. It works through both local excitability and widespread network effects. And this is an area which continues to evolve in both clinical and experimental domains. These are the take-home messages which I expect all of our participants would gain. This is a non-invasive neuromodulation technique. It is the neuroplastic changes that we are targeting. The most common target is the DLPFC, the left DLPFC for depression. And efficacy is linked to the modulation of broader brain networks. This is a promising tool with growing applications in psychiatry. You can go for further reading. There are books and videos available for understanding rTMS. I would end by my favorite quote, that if the human brain was so simple that we could understand it, we would be so simple that we couldn't. So it is definitely hard to understand the brain, but all these techniques are helping us to gain more and more access to our physiology, and therefore devise more treatments for our patients. Thank you for patient listening.